Before starting glaucoma, it is necessary to know about the aqueous humor, that how it is produced, what are the components of aqueous humor, how it is suppressed, because suppression of the aqueous humor is the only tool to control glaucoma. Aqueous outflow, we should know about trabecular meshwork, Goldman tonometry and other forms of tonometry before starting about the different types of glaucoma. So glaucoma is a term that is used to describe a group of conditions that have in common certain changes. Certain changes are common in these group of conditions. And the first change is chronic progressive optic neuropathy. So the optic neuropathy should be chronic and progressive. Another point is this neuropathy will result in characteristic morphological changes at the optic nerve head. And in the retinal nerve fiber layer, and these changes will be present in the form of excavated appearance of the optic disc known as cup disc, and there will be loss of retinal ganglion cells and their axons. This progressive retinal ganglion cell death and visual field loss, there will be corresponding visual field loss. They are associated with these changes. And another important factor in glaucoma is intraocular pressure. It is a key modifiable factor. It is a risk factor and it is a modifiable factor. We can modify the IOP and control the glaucoma. So 5 points, these 5 points are important in glaucoma. Classification of glaucoma. Glaucoma may be congenital or acquired. Congenital or developed is also known as developmental. Glaucoma can also be divided into open angle and angle closure. The open angle and angle closure are further, both can be divided into primary and secondary glaucoma. Primary open angle, secondary open angle, primary angle closure and secondary angle closure. We will discuss each of these in detail. Epidemiology: 80 million people are worldwide affected. Above the age of 40, 3.5% in the population have glaucoma and 50% may be undiagnosed. So this is a huge number, undiagnosed. So first of all, aqueous production. It is produced from plasma by the ciliary epithelium. This is ciliary epithelium and this is ciliary stroma. The ciliary epithelium, and this occurs in the pars plicata. So there are totally 80 ciliary processes. 80 ciliary processes, and each ciliary process contributes to aqueous production. And the process consists of active and passive transport. First of all, a high protein filtrate passes out of the fenestrated capillaries. This is known as ultrafiltration into the stroma of the ciliary process. This is the stroma. So first of all, a high protein filtrate passes out of the fenestrated capillaries into the stroma. This is known as ultrafiltration, from which active transport of solute occurs across the dual layer ciliary epithelium. This is dual layer ciliary epithelium. So this then active transport occurs through this epithelium. The solutes are sodium, chloride, bicarbonate and other ions. This produces osmotic gradient, and this then facilitates the passive flow of water into the posterior chamber. This is posterior chamber. So here osmotic gradient is established, so which attracts water. This whole process, 2 to 3 microliter per minute aqueous is produced while a person is awake. So per minute 2 to 3 microliter. It decreased by 50% during sleep. In the aqueous humor there is high hydrogen and chloride ions and high ascorbate, high hydrogen and chloride, high ascorbate and low level of bicarbonate. And it is protein free, about 1/200 times the blood aqueous due to blood aqueous barrier, and the protein free for the optical clarity. So these are the components of aqueous humor. Aqueous humor contains a lot of things like growth factors, the enzymes like carbonic anhydrase, lysozyme, diamine oxidase, plasminogen activator, dopamine beta hydroxylase, phospholipase A2, prostaglandins, cyclic adenosine monophosphate, catecholamines, steroid hormones, hyaluronic acid. The function of all these components is I don't know the function of all these. So if any one of you know the functions, please let me know in comments. So the main aim of glaucoma treatment is to suppress the aqueous humor production. So the aqueous humor is suppressed by 3 mechanisms, and the first one is inhibition of the enzyme carbonic anhydrase, provide the bicarbonate ion. So when we inhibit the enzyme carbonic anhydrase, it provides the bicarbonate ion, and the process is blockade of beta 2 receptors. So it decreases either in the efficiency of sodium potassium adipase or in the number of pump sites. And there is stimulation of alpha 2 receptors. So it decreases in ciliary body blood flow. So the blood flow is decreased through inhibition of CAMP. So these drugs are very commonly used. Some of the drugs they follow the first mechanism, some drugs follow the second mechanism, and all of you have seen these drugs. They are common use. So beta 2 and alpha 2 have opposite action. Now the mechanism of carbonic anhydrase. The carbonic anhydrase produce aqueous humor by creating osmotic gradient. So this osmotic gradient then attracts water. Carbonic anhydrase produce bicarbonate and hydrogen and sodium, and this then attracts the water. So by blocking the carbonic anhydrase, the osmotic gradient is reduced and the aqueous humor production is reduced. Now the aqueous outflow, it is through trabecular meshwork, and this trabecular meshwork study is very important because the most common surgery, trabeculectomy, is related to this trabecular meshwork, and other glaucoma management new technologies are also using this trabecular meshwork, intervention in this trabecular meshwork, like Ahmed valve and a lot of valves, they are now produced. So this trabecular meshwork is very important, and it is sieve-like. You can see it is a sieve-like structure, and it is found at the angle of the anterior chamber, and through which 90% of the aqueous humor leaves the eye. 90%. It has 3 components, mainly 3 components. So this trabecular meshwork, it is a one-way valve, and so it is a one-way valve having 2 leg to 3 leg trabecular cells per eye. It decreases with age. In older adults, there are more pigmented granules. This is trabecular meshwork. We will discuss each part in detail. Trabecular meshwork has three parts. First one is uveal meshwork. Uvea means it is attached to the iris. Then the corneoscleral meshwork, external to the uveal meshwork, and then juxtacanalicular, also known as cribriform meshwork. It is the outer part of the trabeculum and links the corneoscleral meshwork with the endothelium of the inner wall of the canal of SCHM. So the uveal meshwork is the innermost portion consisting of cord-like endothelial cell-covered strands arising from the iris and ciliary body stroma. This is ciliary body stroma and this is iris. The intertrabecular spaces are relatively large and offer little resistance to the passage of aqueous. Next is the corneoscleral meshwork. It lies external to the uveal meshwork to form the thickest portion of the trabeculum. It is composed of layers of connective tissue strands with overlying endothelial-like cells. So this is corneoscleral, this is uveal, and this is corneoscleral. The intertrabecular spaces are smaller than those of uveal meshwork, conferring greater resistance to flow. The last part is juxtacanalicular, also known as cribriform meshwork. It is the outer part of the trabeculum and links the corneoscleral, this is corneoscleral meshwork, with the endothelium. This is endothelium of the inner wall of the canal of SCHM. This juxtacanalicular, it consists of cells embedded in a dense extracellular matrix with narrow intercellular spaces and offers the major proportion of normal resistance to aqueous outflow. The three layers can also be seen here: uveal meshwork, the corneoscleral, the juxtacanalicular, and this is the SCHM canal, and this is the interior chamber, the iris and interior chamber. This is the ciliary muscle. This is the scleral spur, which we will discuss. This is the inner wall of canal of SCHM. This is the collector channel, intrascleral vein. So this is the flow of the aqueous. This is the flow of aqueous. Now we will discuss this SCHM canal. So this is a SCHM canal. It is a circumferential channel within the perilimbal sclera. The inner wall is lined by irregular spindle shaped, you can see here, this is the inner wall. The inner wall by irregular spindle shaped endothelial cells containing infoldings called giant vacuoles that are thought to convey aqueous via the formation of transcellular pores. The outer wall is lined by smooth and flat cells. These are smooth and flat cells, and these are spindle cells, spindle shaped endothelial cells, and these are smooth and flat cells, and contains the openings of the collector channels. These are the opening of the collector channels which leave the canal at oblique angle and connect directly or indirectly with episcleral veins. The septa commonly divide the lumen of the SCHM canal into 2 and 4 channels. So it is a circumferential channel of diameter about 200 to 300 micrometer in the perilimbal sclera. And these are the episcleral veins. So again, this is the trabecular meshwork and the SCHM canal. The anterior chamber, the aqueous humor goes through these green arrows into uveal meshwork and corneoscleral meshwork, juxta canalicular meshwork, and then the SCHM canal. As we go towards the SCHM canal, the resistance become increase and increase. Now the physiology. The aqueous flow from the posterior chamber via the pupil into the AC, from where it exits the eye via three routes. There are three routes. First, it comes from the posterior chamber into the anterior chamber, and then one route, second route, and third route. One route is trabecular meshwork. 90% outflow occurs through it. Trabecular meshwork. And uveoscleral drainage. The uveoscleral drainage is 10%. Trabecular meshwork 90%. So it goes from the trabecular meshwork into the SCHM canal, and then the episcleral veins. This is a bulk flow pressure sensitive route, so that increasing intraocular pressure will increase outflow. So the episcleral veins are connected to anterior ciliary and superior ophthalmic veins, and then to the cavernous sinus. Uveoscleral drainage is 10%. Unconventional, it occurs through face of the ciliary body into the suprachoroidal space. Face of the ciliary body into the suprachoroidal space. This is suprachoroidal space, and is drained by the venous circulation in the ciliary body, choroid, and sclera. Some of the aqueous also drains via the iris. The third part is iris. The next topic is intraocular pressure. Intraocular pressure is determined by the balance between the rate of aqueous production and the rate of aqueous outflow. The aqueous outflow is related to the factors that include the resistance encountered in the trabeculum and the level of episcleral venous pressure. Concept of normal intraocular pressure. The upper range of normal for adult is 21 mm of mercury on applanation tonometry, which we will discuss. Some individuals develop glaucomatous damage with intraocular pressure less than 21, but others remain unscathed with intraocular pressure well above this level. So reduction of intraocular pressure is a key modifiable element in all types of glaucoma. Additional incompletely understood factors are critical in determining whether a particular individual or eye develops glaucomatous damage. These include factors affecting the susceptibility of the optic nerve to the damage, such as the integrity of its blood supply and structural vulnerability to mechanical stress at the optic nerve head. If fluctuations occur, normal intraocular pressure varies with time of the day. This is known as diurnal variation. It also varies with the heart beat and blood pressure and respiration. The diurnal pattern varies with a tendency to be higher in the morning and lower in the afternoon and evening. This is at least partially due to a diurnal pattern in aqueous production, which is lower at night. Glaucomatous eyes exhibit greater than normal fluctuation, the extent of which is directly proportional to the likelihood of progressive visual field damage, and a single reading may therefore be misleading. It is good practice to note the time of the day in conjunction with the recorded intraocular pressure.